Okay, let's shift from the most urgent topics like treatment of aneurysm and treatment of malformations and talk to a different field and talk about neuroradiology and where this treatment can be most helpful, and treatment of hematomas. It's the very urgent topic that's been studied for a number of decades. Such factors in inflammation and angiogenesis that affect the formation of neuromembrane. It's a very important factor, and the anatomic structure as the brain and trabeculars. And these areas where our lesions occur and where SAH happens. So we are looking for additional factors why such problems occur, how they develop, what role angiogenesis play. This slide demonstrates how a new vessel develops, and we see how SAH develops in time. This is not a stable process. It's a dynamic process that explains why hematomas grow inside and why a stable situation changes so abruptly, and they have to be operated this way or another. We are currently living in time when the people are getting older, and the analysis of the dynamics demonstrates that this kind of complication is going to occur faster and faster. In order to work with SAH, you have to understand where mostly likely to come from. These are the mostly external carotid artery, and Ashkar and his team have demonstrated that a cutting tissue, these are the tissue that are related to the vessels of brain, and from that time we have seen a number of publications on how to close certain feeding vessels and certain feeding areas, and there we have seen certain divisions between Asian authors and other authors, and that have different views on what we should involve in this works, whether it's an independent method of treatment or some supplementary technique. In the year 2019, a U.S. clinical trial was started after SPVA study was published. They made a step further and started to use non-adhesive material, and this study is currently going on in and it involves onyx to treat SAH. And being impressed, we in St. Petersburg started to use onyx to treat subdural hematomas, and our experience was elderly compensated patient, but our very first patient suffered of headaches, retardation, and he had no anticoagulation. And when you start this work, you analyze the external carotid artery, and when you shift to MMI, you may see this additional network that starts to play a very important role with time, and this is the region that could be characterized as a cotton tissues. The tissue shouldn't avoid a dangerous anastomosis zone as well. And when you work with different particles assemblies, you have to understand where they move, and dangerous bypasses should also be taken into account. And look at the way it can be seen in this or that particular patient. What you see, what you have to keep in mind, and the more distal the catheterization, you shouldn't stop at the distal part of the MMA level. And we took non-adhesive substances of different viscosity because we thought we could obtain maximum distribution, and this is the first portion that has traveled quite far, reaching the collaterals on the other side. And after that, you either stop injecting before squid 12 forms no plug, or you have to stabilize your reflux zone. Squid 18 here becomes essential. And after you stabilize with squid 18, you may try to open all these gateways into these microcapillary and continue with squid 12. Look at the network that has opened. What's different with PVA? You inject it once and you stop, but here you've got quite a lasting embolization that has filled all these cotton filled, and it all took 20-25 minutes to perform. And what is important here, we can see that the person with the craniotomy on the one side and the hematoma has completely dissolved. And what it gives us a certain reserve in time. So what happened? The patient had his trauma in October. He suffered of vomiting and nosiness, and the symptoms kept increasing. We could see the second bleeding. In a week, we performed one more study, and we could see more lesions. So the compression kept increasing. So these were the lenses that pressurized the hemisphere, and we could see the dangerous anastomoses, those that areas that suffered due to the trauma, and thanks to it, we could reach the capsules and observe all the network. And this is the zone you had to control. And having analyzed how non-adhesive substance spreads, it goes in and close all the collaterals, the closing all the hypertrophic vessels. And after that, the same tactics can be used on the other side, and you can see how all the MMA complex with all the additional branches and everything and getting closed. Together with the atypical vessels in the dura. And what was important to understand after that, we had to understand whether he had achieved anything or not. And then the hematomas start to reduce and then dissolved completely. So within a week, a significant improvement was shown, and we observed them for a few months. The initial control terms moved a little bit, but anyway, we were able to see the interval when such hematomas successfully dissolved. What is his current status? His complaints has gotten minimized. you can see that the new vessels are closed completely, and unless it's difficult to say because we haven't removed them so far. The embolization time took less than 2 hours. We used squid 12 first, followed by squid 18 and squid 12 again to open the gateway once and again. It's a completely different approach because we could see what exactly we embolized, so we could keep contact with the patient, and even when everyone was scared by COVID, they came and performed all the controls. And here's one more situation: another elderly patient that suffered of the of a trauma, and she turned to the surgeons, and they suggested trepanation, but it involved a lot of risks. And we took this patient with the sufficient level of paresis for embolization. You can see injured meningomedia, and these are what you see. We use Sonic 1 and 2. It was quite difficult to get through, but nevertheless, network, we could see how interesting it is when you start working with squid after reflux stabilization. And this is the foramen branch. We couldn't catheterize, but as soon as the reflux reached the dangerous anastomosis, we had to stop.
Можно сработать ониксом, так можно сработать сквидом 18. Вот она, одинокая нитка. И рядом специально выведена отдельным полем работа сквид 12, сквид 18 в комбинации и достаточно длительной.
We can use onyx, we can use squid 18.
Разница, она очевидна.
Pretty long penetration, pretty long distribution. And the opposite side, we worked on the right side first, and you can see a large cotton tissue area. And we managed to record the first distribution of squid 12.
Если не торопиться, создать вот эту вот первую пробку, эту порцию, которая
заполняется,
после чего можно...
It moves backwards. When it fills the vessels, then we can move to squid 18. And you can see this new vessels filled. These are new formations, new vessels that create a network of these new vessels. And after a few days, we see regress of paresis. And in 2 months, this patient has no paraplegia, and she can walk, and she is active again. Hematoma in a patient of 67 years old. There is a big dislocation of more than 1 centimeter. But he came to our hospital and to our center. It means that we have a little bit of time. And after embolization, in a month, there were no complaints and no tracks of hematoma.
Вы гематому сказали бы, вот все замечательно.
So, in case we use traditional approach with trepanation, we would see air in the place of hematoma. But here we see an absolutely different result.
Группа небольшая, в силу многих обстоятельств.
So this group is small due to various factors.
Куда вот эти пациенты попадают?
We have federal center where this patient come not directly. The last group of patients show a significant improvement in their state and their condition, and they have very good results and outcomes. There are no significant complications because distal catheterization is your safe net. It's a guarantee of safety. And if you control the distribution of the embolizer, you can achieve great results without open surgery. Various viscosity. You can say that maybe squid 18 will behave the same as squid 12. But it's not really true. If we use squid 12, that is more suitable for hypertrophic small capillaries that were not there at the beginning. Using squid with less viscosity is beneficial than using squid 18 with high viscosity. Because we can get leisure of the scapula of the vessels. In case of tortuosity and when distal catheterization is not available, you can use squid 18 after very detailed analysis of all dangerous anastomosis. And non-adhesive embolizers can be easily controlled than PVA. And general anesthesia is a prerequisite. Yes, that's a drawback of our technique. But if you have a good anesthesiological team, it doesn't make any difference for them.